evening here in Pakistan, Karachi, Pakistan. I'm again very much thankful to International College of Dentists for including me in their team and to present internationally on this forum. Special thanks to Professor Mohammed Ibrahim, Education Chairman of 15th ICD, for organizing my talk. Professor Mohammed Ibrahim already organized me, and today the topic, I will just not go in my details. The topics of my presentation today is basics of clinical orthodontics. Today mostly I will be talking about with the general dental surgeons, that how can they help in orthodontics. And in this presentation today I will discuss about best time for orthodontic checkup and treatment. What are the problems to watch for in 7 years? Advantages of early treatment. I will also discuss importance of orthodontic records. Treatment options for adult patients. What are the different treatment options available? And the last two slides are most important. I will also discuss about aligners. What are the cases in which we can just give aligners, impression taking, and different aspects of aligners I will discuss with you. And in the last slide, in the last part of my presentation, I will discuss with you sleep breathing disorders, that how it affects the life expectancy of patient, and being a general dentist, how can we help in diagnosing sleep breathing disorders and how this affects the life expectancy of a patient. So starting from the first part of my presentation, best time for orthodontic checkup and treatment. This is the most frequently asked question from the general dentist. I can also remember when I started my practice, still parents come and ask, and dental students ask, what is the best time for orthodontic checkup and treatment? Most previously, the old school of thought was that bring child after 12 years of age for checkup. That is the old fashion. And now we recommend 7 years. That's why problems to watch in for 7 years. What's the reason we call for 7 years? I'll just discuss. This is most important slide, in which center is Professor Arif Alvi with the yellow tie, and adjacent to him a first lady, and I am present. Professor Dr. Arif Alvi is my mentor and my supervisor, postgraduate supervisor of orthodontics. He is currently the president of Pakistan, Republic of Pakistan. So our president is a dentist, very good dentist, and orthodontist. So orthodontist we recommend checkup around 7 years of age. This is most important slide. Most asked question from parents or patients, when to bring child for examination and treatment. Previously, as I discussed with you, dentists and students recommends that 12 years is the time when a patient should come for orthodontic examination and treatment. But now this has changed. And what's the reason for that? Most of the time when patients come at 12 years of age, for most of the malocclusions in which we will discuss which malocclusion we have to address around 7 years of age. And if the patient comes around 12 years of age, the boat is missed and we are not able to treat some of the malocclusions at that time. So the reason we recommend checkup around 7 years of age is because first molars erupts at that time with the establishment of posterior occlusion. First molar posterior occlusion can be established. Anterior, posterior, and transverse relationship of the occlusion can also be established at that time. We can discover functional shapes or cross bites. Incisors begin to erupt and problems can be detected, such as crowding, habits, deep bites, open bites, and some jaw discrepancies. We does not advocate comprehensive orthodontic treatment of every problem, every malocclusion during that time. But interceptor treatment may be started at this age. This is very important slide in which I have shown you problems to watch for in 7 years old. Like these are the problems, and I'll also discuss with you the solution. I will also discuss with you the solution of these problems and how can we diagnose it early. And as a general dentist, we can benefit. You can diagnose your patients early. You can start with interceptive orthodontic treatment, or you can refer it to orthodontist, so that you are doing a big service to orthodontic association or orthodontics or your patients. The number one top right picture is anterior crossbite. When you see such type of crossbites, it's the time we recommend treatment as soon as possible. We can just treat these type of anterior crossbites by either removable appliance with finger spring or Z-spring, or either we can place fixed braces. But it's better to treat as soon as possible, because if the patient is growing in such crossbites, then chances are that dental malocclusions, dental problems may convert into skeletal problems. So similarly, if you see a posterior crossbite and posterior crossbite is seen, we again recommend to start treatment around 7 years of age. 7 years of age, as I have already discussed, that incisors have erupted, molars have erupted, most first molars and incisors. So and if you see a posterior crossbite in any patient, the option of palatal expansion is there. So correct the problem with palatal expansion. We have different options of palatal expansion. We can do slow expansion, we can do rapid expansion, we can do semi-rapid expansion, and there are different appliances available to correct posterior crossbites. In a rapid expansion, we recommend around 2 turns per day. In semi-rapid, around 1 turn alternate day, and then 1 turn weekly we can recommend. Hyrex and different other appliances are available for the treatment of such problems. And if you see such crowding in the third top slide, if you see severe crowding, then again it's better to do interceptive orthodontics in such patient. We don't wait for malocclusion to get worsen and then start our treatment. So for correction of crowding, we can do serial extractions. In serial extractions, if there is a protocol to do serial extractions, if the crowding is severe and if the patient is class 1 angles malocclusion, then we can do serial extraction. The serial extraction protocol is we extract first primary C cuspid, then extract D, and then once the 4 is first permanent molar, premolar is when erupted, we extract it. So the formula is C, D, and 4. C is extracted around 7 to years of age, then D is extracted, and then 4 is extracted. We do extraction in all arches. So as I have already mentioned, if the patient is class 1 and there is no skeletal problem and there is no associated anomaly of any other tooth, then we can do serial extractions. And in some of the cases that we have seen that the problem is resolved only with this serial extraction. And then in few cases, there is no need of comprehensive orthodontic treatment. Otherwise, if some problem is left, we can do comprehensive orthodontic treatment later on. Similarly, if such open bites are present, 7 years is the time in which we can start treatment, 7 to 8 years of age. This type of open bite is seen because of any habit. If the patient has habit of finger sucking, digit sucking, then we can see such type of problem in patients. So it can easily be resolved at that time. And mostly parents also come for consultation and ask that what is the best time for open bite. We don't mostly treat these type of conditions in primary dentition, like before 7 years of age. We wait for 7 years of age. And if we intercept during that time, then the chances are that the skeletal deformity or open bite, whatever changes have done because of the digit sucking habit, it can be reversed if we are starting treatment at 7 years of age. But if we are starting treatment at 12 years of age and afterwards, in these open bite conditions or cross bites, then the chances are that the simple problem can be converted into more complex problem, and more complex orthodontic treatment is required in such type of cases then. So if you see a patient is coming around 7 years of age, just as soon as possible start treatment, just give habit breaking appliance at that time. And because of habit breaking, and this open wide will autocorrect, and if the cross bite is present, high arch palate is present, you can also give palatal expander with habit breaking appliance. The other slide, protrusion. There is a research that if the incisors are kept uncovered with lip, then the chances are there that the fracture of that incisors may occur. So we can start in this type of malocclusion protrusions, we can start treatment early if the incisors, upper incisors are uncovered. If incisors are covered good by lip, then we can start treatment later on also. But it's better to, and mostly I've seen in class 2 division 1 cases, that if the maxillary incisors are like that, then most of the patients have fractured incisors. So then they might have root canal treatments or other prosthesis on that. So if you treat this patient early on, then it's a psychological benefit also to the patient. If you see ectopic eruption, and mostly we start also treatment at that time also, and if you see such type of ectopic eruption, we manage that also. We create space and push first molar back. In the incomplete class 3 cases, if you see such type of malocclusion, we have to start treatment early. In class 2 malocclusions, we can defer treatment later on around late mixed dentition stage or early permanent dentition stage. But in class 3 angle cases in which such type of malocclusion is present, in which reverse overjet and overbite is present, and in which cross bite is present, we have to start treatment early. And the treatment protocol is, if the posterior cross bite is present, to give palatal expanders in that, and if anterior cross bite is present, we give reversible headgear or face mask in those patients. So there's a protocol of giving reversible headgear or face mask. So these type of patients, if we correct early, we can correct them completely and convert them into skeletal class 1 once they've achieved into early permanent dentition. And if the boat is missed at this time, then there are chances that these patient either extraction is needed. If severity of problem is more, then there are chances that TADs or skeletal anchorage devices might be needed. And then if the problem is more severe, then for the correction of class 3, we need orthognathic surgery, very invasive procedure. So it's better to check patients around 7 years of age, to recommend dental surgery. We recommend dental surgeons to convey this message to the parents and the community that it's better to come for orthodontic checkup and screening around 7 years of age. Okay, if the diastemas are present, we correct that, watch for them, and we correct that and create space for canines and premolars to rub. And in the last part of this slide, if we see oral habits, we have discussed already in open bite cases, such type of oral habit. If we see open bite, either there is tongue thrusting or there are digit sucking habits or any other habit, treat as soon as possible, give devices in which the oral habits are reversed and the patient malocclusion will be corrected. So this is very important slide. And if sorry, I forgot to ask, if anyone has any question, just ask, and you can interrupt me in between, and I would like to give you answers during my presentation. So these are the very important conditions in which if we pick these problems early and we start treatment around 7 years of age, then the chances are that we can easily correct with very simple mechanics, we can correct these problems, and patient might not later need treatment or need simple treatment. So if the patient, old school of thought that the patient is coming around 12 years of age, most of these treatments are missed and the problems may become severe. And now, what are the advantages of early treatment? The advantages of early treatment are that there is a reduced risk of trauma. We eliminate growth local disturbances. Craniofacial tissue is more malleable, and like we can do growth modification easily. Psychological advantage, especially in class 2 cases, and if the patient is having psychological trauma, if the child is saying that he have bunny teeth, or if in school his colleagues are saying that the problem is socially taboo, then it's better to treat early. And even some of the class 2s in which we recommend the best time of treatment of class 2 is around, as I already mentioned you, late mixed dentition or early permanentation. But because of this psychological trauma, we treat class 2 early as we treat class 3. Elimination of gingival and palatal trauma, especially if this is present with class 2 deep bite cases where there is a traumatic deep bite. And if we treat early, there is an improved prognosis of adolescent treatment. This is the other part of my presentation with you, in which I will discuss if you are linked with seeing orthodontic patients or other patients, or you're referring patients, then orthodontic records and how to proceed with that. It's better to accustom yourself with that. When patients come to us, history and the initial questions, what is the reason for treatment, it's very important. And then when we are making our treatment plan, when we are making our problem list, we just keep patient concerns on top. And so the history, medical history, where he lives, his social history, his problems, past medical history, all are important, so that our treatment planning, our modes of treatment are all linked with this. Then clinical exam is also important, like check the health of the tissues, jaw function, facial proportions. And then when we are linked with orthodontically treating patient, we just take their impressions, take pictures, extra and intraoral pictures, do SEFs and OPGs. So if you are anywhere linked with orthodontic treatment, orthodontic care of patient, any general dentist, any orthodontist, it's better to go through all these things. Taking impressions, these trimmed casts are important. You can see right, lateral, frontal, and different views, mandibular and maxillary cast. When we keep the patient in centric occlusion trimmed cast, we can have a fair idea. If the patient is not there, we can have a still fair idea with the cast of the patients, and we can calculate crowding, Bolton's discrepancy, our jet, our white accurately using these casts. This is a very good screening radiograph OPG. This is one of my patient in which he have facial asymmetry. His chin was shifted towards left side. I'll show you one of his picture, pre and post treatment picture. This is a very good radiograph in which we can see supernumeraries, any pathologies, deep notch. In this patient, we can see deep notch at the right side of the patient here. At the left hand side where missing molar, we can see the deep notch, more retrusive mandible, short carpus, small ramus, greater gonial angle, lower face height is increased, mandible plane angle, vertically directed. So this is a very good screening radiograph in which we can see decayed, missing, filled teeth, prosthesis, and any other pathology. Cephalometrics, if you're treating patient orthodontically and if you are linked with the care, then this is a digitally traced ceph. We use Dolphin for tracing. You can manually trace this. And the different, we in cephs can compares cranium to the maxilla, cranium to the mandible, maxillary dentition to the mandibular dentition, maxilla with the mandible. We can see soft tissue, we can see skeletal tissues. So the different analysis present in which we can see anterior posterior sagittal analysis, we see SNA, SNB, ANB, widths, and Harvard analysis. And in vertically, we see Serra-Nazion mandible plane angle, Frankfurt horizontal plane, anterior face heights. So, and for soft tissue, we see nasolabial angle, upper lip to upper lip to S point, and upper lip to Ricketts C plane, lower lip to S plane, Steiner's plane, and lower lip to Ricketts E plane. These are the few readings which you should be accustomed if you are linked with orthodontic care. This is my patient which I was talking about. The picture quality is not good. If you see the mandibular arch, the reason is this patient had history of trauma in childhood, and because of that, his left side was disturbed. And had trauma of left condyle. Right side is growing normally. His chin, you can see in the facial frontal photograph, his chin is directed towards the, shifting towards the left side of patient. So the right side is normal and it's growing normal, and the patient chin is shifting towards the side which is left side which has trauma. So we have different, when this patient visited us, we have different his expectations at that time. He want proper mouth opening and chin asymmetry to be corrected. So if you are linked with orthodontic patients, referrals or treatment, better to go with all these things so that we can formulate a better problem list and so treatment plan. These are some of the radiographs in which if pictures and radiographs in which if the pathology asymmetry is present, then we recommend such investigations. You can see original frontal picture with midline. We can see how much the chin is deviated through this radiograph. Chin is deficient on the right side and shifted towards. We can also see in this frontal photograph turkey gobbler appearance, double chin. And if you see the CV 3D reconstructed CT scan, we don't recommend 3D reconstructed CT scan on every patient. If the patient is of asymmetry, and if we are going towards orthognathic surgery, and if he have any other anomaly, asymmetry in face, then we recommend such 3D reconstructed CT scan, in which also you can see the midline, the lower dental and the facial midline mandibular is also, you can see is shifted towards the left side. And the next radiograph, if the 3D CT scan is not present in some areas, you can go for PSF radiograph. This is also digitally scanned, and we can just see how much, quantify how much asymmetry is present in these radiographs. The next part of my presentation is adult orthodontics. These days, adult patients coming to orthodontic clinics has increased dramatically. And what's the reason for that? Adult population is increasing. According to American Association of Orthodontics, the number of adults currently in orthodontic treatment has increased from last 10 years, 1 in 25 to 1 in 5 patients. Why? Because the birth rates are declining in most of the world. The information age has made adults more aware of their treatment, and they are more aware of themselves. We used to take selfies. I'll discuss about that. The type of treatment option available has become more user-friendly. Like initially there were only metal brackets, now there are ceramic brackets, aligners, lingual treatments. Adults want aesthetic treatment, without aesthetic impairment. Any type of appliance, I will discuss with you the role of aligners, and they are becoming more famous. What's the reason for that? The reason for that is more of the adult patient are visiting orthodontic clinic these days as compared to last few decades. And what is the meaning of this? We want aesthetic treatment is that there are different components of malocclusions, like physical component of malocclusion and Psychological component of malocclusion. Any appliance like metal braces, ceramics, lingual braces, aligners can handle that physical component of malocclusion, like what is angles class 1, we can correct class 2, class 3, crowding, open bite, other all problems with. But the psychological aesthetic impairment is psychological component is patient wants to correct these problems without any that the treatment is not visible to her. So we go for lingual braces. These days there are incognito gold braces available which we place inside. Those are totally invisible. And the aligners these days, aligner therapy have increased. And the reason for adults coming to orthodontic practice is this inflammation to take selfies, selfitis. Now we are using with the arm length, we are using 40 megapixels phone, and the smaller problem can be visible magnified. Patient visits and see doctor. We are not from this angle, our teeth are not looking good from this angle. So facial aesthetic treatment, dental treatment, adult patient visiting orthodontic clinic, dental clinics have increased alarmingly. So that's why I'm discussing what are the adult orthodontic challenges. If the adult patients are increasing, what are the adult orthodontic challenges? There is no help from growth, so growth modification can't be done. Aesthetic demand of these type of patients is higher. In adult patient, tooth movement is generally slower to start. Original problem most likely might be complicated with missing and decayed teeth. So we have to formulate a treatment plan. If there are missing teeth, decayed teeth, we have to incorporate that into our treatment plan also. In some presentation with International College of Dentists, I'll love to discuss with you the treatment plans of different malocclusions. What are the treatment options available for adult patients? There are metal brackets, but not the first option if the patient aesthetic demands are high. Ceramic brackets, aesthetically better. We have white wires also available, tooth colored wires also available, which are less visible. With ceramic brackets, we can use self-ligating brackets, which are available in metals and ceramics. Aligners, I will discuss more about aligners and lingual braces. These are the options. The last two are aligners and lingual braces are the options if the patient aesthetic demand is high in adult patients. Aligners, these are the, I will talk in this part of my presentation, I will talk how we take impressions with aligners. For each patient, orthodontist submit digital impression, digital bite, or polyvinyl siloxane impression with bite registration. We submit OPG, lateral ceph with tracings, extraoral and intraoral pictures, complete filled form with treatment plan. I would like to give emphasis on that plan that either whatever is the problem, class 1, class 2, class 3, the modality of treatment, either metal bracket, ceramic bracket, aligners, lingual bracket may differ. But orthodontics and dental knowledge of treating that patient remains same. So we have to go through all records of the patient, history, then pictures, extraoral and intraoral pictures, then impressions, trimmed cast, OPG, ceph is important to make a thorough problem list and to come on a conclusion and make treatment plan. So either you are using aligners or any other mode of treatment, the good treatment plan is important for the success and for better results. In aligners, we have these digital laser scanners. Initially, we do polyvinyl siloxane impressions. I will discuss with you the conventional impression with polyvinyl siloxane, putty, wash. But with aligners, if we do comparison between conventional impressions and laser scanning, digital impressions, if the bubbles are present in conventional polyvinyl siloxane impressions, then the manufacturer will say repeat the impressions. And it's seen that these digital impressions results in 7x more better than the conventional impressions. And there are 10x fewer rejections if you're using these digital laser scanner digital impressions. These digital impressions are more superior in many aspects than the conventional. So this is the digital scan. See, this is my patient visited me a few days back. We are doing the digital scan of this patient, maxilla, mandible, right occlusion, bite we take, and it's very easy for the lab and us to construct appliance and the appliance. And these aligners treatment results depends mostly on the precise impression taking and the accuracy of the impressions. With the digital scanners, the accuracy is 7x more than the conventional impression taking. And so the fit of the aligner is more better with digital scanning. And just see, after we send the digital scan or polyvinyl siloxane impression to the lab, they send us this pre and post treatment digital models. In this you can see, in this you can see pre-treatment. This is pre-treatment, and then what happens afterwards, step by step. So when they send us digital setup, we can see pre-treatment and what are the post-treatment effects. And if there is any, especially in conditions in which there are more complicated problems, complex problems, missing teeth, then the chances of going through the treatment plans are more better, and we can give more better service to the patient. The conventional impressions, if the digital scanners are not available in your practice or in your country, then you can go with these conventional impression taking for aligners. These impressions are a bit different from the impressions we take with the crowns and bridges. We use spacers between impressions. But with the impression, these spacers are used, and when we remove the spacer, the impression is wash impression, so that the details of the teeth and the gum can be recorded very accurately. So the first stage we take impression with a putty, and then remove the spacer, putty with a spacer, and then we remove the spacer and take impression with wash. You can see the main areas of concern are the teeth and the gums around teeth. If there are bubbles present at that time, you have to repeat your impression. This is maxillary impression. Why polyvinyl siloxane? Polyvinyl siloxane is considered accurate impression material, has excellent recovery, minimal permanent deformation, superior tear strength, can be stored for a long time, can be disinfected, can be duplicated multiple times. How does aligner work? 2 weeks per aligner where is recommended. Aligners move teeth in a small increment, 0.25 to 0.3 millimeter, 2 week per aligner works. Require minimum of 20 to, this is very important. If the patient is not wearing the appliance 20 to 22 hours, there will be no results. 350 to 400 hours wear per aligner will be effective. What are the advantages? Aesthetic, good hygiene, less chairside time, can be used with any restorations of crowns, comfort, removability, bonding to enamel defects like amelogenesis imperfecta or dentinogenesis imperfecta. When bonding is challenging, we can use aligners easily. These are non-traumatic. Bleaching during treatment can also be possible. Not all type disadvantages are that not all type of malocclusions are treated with aligners. Root movement difficult to achieve, can be misplaced and lost. Extraction cases difficult to treat. Patient compliance is a major factor. Cost is higher than the conventional treatment. Changing treatment plan is difficult during treatment because we have to scan, we have to order for scan again and then remake of all the aligners again. IPR is done in mostly it relies on IPR, intraproximal reduction. There are like mild, moderate crowdings, deep over bites, posterior dental expansions, close, mild, moderate spacing in absolute intrusions. Aligners does not perform well with skeletal anterior posterior discrepancy if more than 2 millimeter, class 2s, class 3s, skeletal components, crowding and spacing of more than 5 millimeter, centric relation and centric occlusion discrepancies, closure of pre-post extraction spaces, extrusion of incisors, high canines. There is also a list in which aligners does not perform well. But the important and the good part is technique is improving day by day. And because of that, moderate malocclusions now are also treatable with these aligners. With the advent of attachments, buttons, we can, to some extent, can move teeth. We can do translation of teeth with these aligners. What are mail ordered aligners? Mail order teeth alignment. These mail order teeth alignment companies are popping up these days, and they're offering orthodontic treatment without orthodontist and dentist observation. They recommend that they will send home kits, and a patient have to take impression themselves and mail to the company. Sometimes this treatment option is good. In few of the cases in when there is a mild problem, but most of the time causes more harm to patient is very important. And it's one of the way orthodontist treat malocclusion. Aligner is one of the way. Checking by orthodontist or dentist continuously that how the treatment is progressing is important. But if the aligners are mailed and there is no one to observe the treatment, then there are chances that adverse effects are more, and treatment, if the treatment is not going according to plan, then also there are chances that the treatment may worsen. And patients are not directly assessed or monitored by licensed orthodontist or dentist. The treatment is not tailored according to patient. Patient during orthodontic treatment needs to be directly monitored even in any ortho treatment options, either by braces, aligners, metal braces, ceramic braces. And that's how we see that how's the plan working. And if there are any adverse effect, we right there change the treatment plan, modify our treatment plan according to the patient. But if the tray is not working as planned, and what if trays are slightly malaligned, not properly fitting, this may start to cause a big problem. Treatment options are limited with mail-ordered aligners. Patients are not thoroughly checked. What are the periodontal status of the patient? They might approve you for the treatment, even you have contraindications like gum disease, palatal expansion, also not good choice when with aligners. So there are few malocclusions. There are very few number of cases in which these are, but mostly licensed orthodontist or dentist is required to treat aligners. So don't recommend, tell your patients that if they are going towards, if some company is marketing mail ordered aligners, it's not a good choice in any case. Outdated techniques, I also already discussed with you that when we compare conventional impressions with digital impressions are more superior in many sense than conventional impressions. This is the same patient which I have shown you before, pre-treatment and post-treatment. The reason for showing you this patient here is teamwork. And this patient visited us that I have a facial asymmetry. Please, doctor, treat me as soon as possible. And I just want to marry. And we planned 2 jaw surgery. in this patient, because when asymmetry is there and one side is not growing, the other is growing normally, then the canting of occlusal plane is also there with the chin shifting of chin. So the Lee Fort 1 osteotomy, upper jaw surgery with the correction of canting of malocclusion, and with that BSSO was done. Later on, if you can see a slight defect, we plan to place a on plant on this area of chin. This is all result of teamwork. If you're working as a team, dentist, orthodontics, prosthodontist, oral and maxillofacial surgeon, we can give better care to our patient. Last part of my presentation is sleep breathing disorder, obstructive sleep apnea. Last year, 2 years back, we had a Pakistan Association of Orthodontics International Conference in the northern part of our area, in which Dr. Derek Mohani was here, and he introduced us this sleep breathing disorder, how to diagnose it, and how it affects our, like we are all dental surgeons involved with decayed teeth, malocclusions, but if we are the first one to open the mouth of patient, and if we see few things which I'll discuss in this presentation, then if we refer the patient to sleep physician, then the life expectancy can be improved. According to United Nations, both sexes average highest life expectancy is of Japan, 83.7 years, lowest is 50.1 years. Our country, Pakistan, has 66.48 years. Our neighboring country, India, has 68.48 years. Iran has 76 years of life expectancy. The most important thing is if we are improving, if we are diagnosing early sleep breathing disorder, the life expectancy of around 10 years can be increased. According to statistics, patients with sleep disorder breathing have reduced life expectancy of around 10 years. Interesting facts about children: a child who snores 4 times more likely to be in the bottom 25% of the class. A child with sleep apnea is 9 times more likely to be in the bottom 10% of the class. 42% of our patients diagnosed by sleep study with obstructive sleep apnea had been started on stimulant medication for ADHD. Attention deficit hyperdeficiency syndrome is often misdiagnosed of OSA. Patients check out their tonsils and find out if they snore. Things you should know about obstructive sleep apnea. With sleep apnea, your breathing during sleep is reduced or may stop. You are likely to only have breathing difficulties when asleep. You may have no idea this happens. It can be associated with other medical problems. Derek Mohani, great orthodontist from Australia, he visited 2 years back to Pakistan, and we conducted international Pakistan Association of Orthodontics conference in Bourbon. It's a very beautiful place. If the things are okay, I would like to invite all of you to visit our country. So he introduced this concept to us. The significance is this: if there is excessive daytime sleepiness, which increases the risk of motor vehicle accidents and diminishes quality of life. Neurocognitive impairment leads to decreased scholastic and occupational performance. Untreated obstructive sleep apnea increases risk of insulin resistance, coronary artery disease, congestive heart failure, myocardial infarction, hypertension, stroke, cardiac arrhythmia, and sudden cardiac death. If you see there are certain symptoms, snoring, nocturnal awakenings, non-restorative sleep, morning headaches, excessive controlling, other medical comorbidities such as diabetes mellitus, hypertension, and obesity, then the chances are that the patient might have sleep breathing disorder. 14% of men are affected and 5% of women. Prevalence rates are higher in certain populations like obese patients considered for bariatric surgery and post-stroke patients. The last we have a white paper printed by American Association of Orthodontists in which they recommend all the dental surgeons and orthodontists involved in patient care that C, open the mouth of patient. C, I will discuss with you how by asking few basic questions you can diagnose patient with obstructive sleep apnea. Apnea is the cessation or near cessation of airflow. It exists when airflow is less than 20% of baseline for at least 10 seconds in adults. Hypoapnea is an abnormal reduction of airflow to a degree that is insufficient to meet the criteria of an apnea. We just see apnea, hypoapnea index. If the cessation 4 or less, which is the normal limits, 5 to 15 episodes per hour of sleep, it's mild obstructive sleep apnea, fifth apnea. If there are 30 and higher episodes, it's a severe obstructive sleep apnea. And the treatment option changes with the mild, moderate, and severe obstructive sleep apnea. As we have already discussed that patient apnea. If you are diagnosing those patients early, because as a oral health physicians, we are the first one, we open the mouth of the patient. And if we see the position of the tongue, I'll discuss with you how you can screen those patients and refer those patients to a sleep physician. These are few of the screening tools. Like we ask these questions as brightness, observed pauses in breathing, BMI higher than 35, age older than 50 years, neck circumference of more than or equal than 17 inches in male, and more than and equal to 16 inches in females. If the patient gender is male. These are the screening tools. Low risk of OSA is present. We ask yes or no to patient. We take next yes or no. We'll stop bank questionnaire. If it's 0 to 2 questions, yes, then it means patient is at low risk of obstructive sleep apnea. If yes to 3 to 4 questions, he is at higher risk of obstructive sleep apnea. Is there 5 to 8? Yes, then there is more higher risk of obstructive sleep apnea. And what is the length of collar size? When a male collar is more than 17 inches or 43 centimeter, or if the female collar is more than 16 inches or 41 centimeter, then there are chances that the adipose tissue is deposited around the neck and it's compressing the pharynx and reduction in the cross-sectional area through which we are breathing. This is questionnaire for children's beers, in which B is for bedtime, excessive daytime sleepiness, A is for altered during the night, awakening during the night, regularity and duration of sleep, S is for snoring. The Bears is a quick 5-item screening tool to be used with children's bedtime issues, excessive daytime sleepiness, light awakening. And again, if you say yes or no, if there are more yes, then refer the patient to sleep physician. As I discussed with you, we are more frequently involved in oral health and we see the patient mouth opening. Patient is not aware that he might have obstructive sleep apnea, child especially. We see for these spaces 1, 2, 3, 4, 5. 1 is palatoglossal fold, 2 is palatopharyngeal fold, 3 are palatine tonsils, 4 are uvula, and 5 posterior pharyngeal wall. We use this modified Malan-Patti test. This has simplified this. We ask patient to seated in a supine position, tongue protruded out without sound. Patient head is a natural head position when his head is parallel to the floor, horizontal with the floor. The modified Malan-Patti, in one you can see soft palate, faces, uvula, and pillars are visible. In 2, soft palate, faces, and uvula are visible. In 3, soft palate and base of uvula are visible. In 5, soft palate is not visible. In 4, soft palate is not visible. So if you see such condition in which the patient mouth is open his tongue is protruding out, and is more that the patient might have sleep breathing disorder, obstructive sleep apnea. So in these type of patients, just refer your patient to sleep physician. He will go for polysomnography, more advanced test, and then he can treat his patient. In this, you can see Malampati classification is a simple test, good predictor of sleep apnea, and in anesthesia also it is used to predict ease of intubation. The third or fourth stage, as I've shown you the picture, there's increased risk of blocked airways during sleep. If such tongue tie is present, then also there is a risk of sleep breathing disorder. The risk factors are obesity, menopause, gender, increasing age, genetic influence, anomalies. Look at these fourth molars. If you open the patient's mouth and you see such big tonsils, this may present with fatigue, weight loss, dysphagia, restless sleep leading to daytime somnolence, and poor school performance, reported loud snoring, recurrent upper respiratory tract infections. Physical examination may present with mouth breathing, revealed noisy respirations with open mouth, halitosis, and tonsillar swelling. This may present with fever or without lymphadenopathy. If you see, if a patient is coming for any problem, like for oral screening, for orthodontic problems, if you see such type of condition, just it's simply with two questionnaire tests, with stop bang and Beer's test, and with Malampati, just look at the soft palate of the patient. If soft palate is not visible, then just ask few questions, and if they are yes, you are doing a big service to that patient. Refer it to physician. And these craniofacial malformations, if are present, then there are chances also that sleep breathing disorders are present. I think so. My time is decreasing, so I'll go fast with the remaining few slides of my presentation. These are the areas of nasopharynx, oropharynx, and laryngopharynx in which you have to see for in sleep breathing disorder patient. So primary snoring is present. If upper airway resistance syndrome, obstructive hypoventilation is present, there are different contributing factors like nasal deviation, septal deviation, contracted maxillary arch. These are the different levels in which we see oral cavity, oropharynx, just see elongation of the soft palate and uvula, tonsillar hypertrophy, macroglossia, retrognathia, ruga area. If these are present with a septal deviation, turbinate hypertrophy, nasal polyps, then the chances are there that the patient might snore or have obstructive sleep apnea. How will you diagnose? Just asking simple questions, stop bang question, Beer questionnaire, examining soft palate, tongue, testings, and evaluation. Clinical protocols are, I'll not go much in detail. We orthodontists are also a team part of to treat obstructive sleep apnea. Polysomnography is a very good test in which we see different things. The goals of treatment is the reduce or eliminate snoring and resolution of the patient's initial symptoms of OSA, normalization of the apnea, hypoapnea index, normalization of oxyhemoglobin saturation. 60% of craniofacial development is complete by age 4, 90% complete by age 12. Therefore, early need of intervention, if any, is important. Cooperation between pediatrician, ENT, orthodontist, and dentist are important for achieving good results. How will you manage? Management is very simple. After you are also the part of the team, just ask patient to do a few lifestyle changes and in behavioral management, weight loss if the patient is obese, hypocaloric diet. There are different treatment options. I will not go in detail again because of the limitation of time. Take-home message for sleep apnea is, if timely diagnosis and intervention is done, then the children with sleep disorders, some of these morbid complications may not be completely reversible, leading to long-lasting residual consequences. Never ignore snoring and upper airway resistance syndrome. Oral appliances are together with medical treatment options to avoid long-term use of CPAP for children. And as a dental health professional, we hold an important position. We are often the first to see a patient and first to recognize that the patient may have an orthodontic problem. The orthodontic's goal is to provide each patient with the most appropriate treatment plan. And if together with the dental issues we are seeing, the patient's oral cavity as a whole, that patient can benefit lifetime if if he has some breathing disorders. So by working together, the dental team, we can achieve results for patients that cannot be produced alone. Thank you very much. Thank you for listening to me. And if you have any questions, you are more than welcome.
Thank you very much, Professor Syed. All right, I see there are two persons who raised their hand. Okay, now I would like to first invite Dr. Jaswant Singh to actually unmute himself. Okay, I have already unmuted you, so you can unmute yourself and then ask questions. Okay, for your information, Dr. Jaswant Singh is an honorary fellow of ICD, and he's very senior. I think he graduated in Lahore, all right, in the dental school in Pakistan also. All right, okay, so Dr. Jaswant Singh, are you here?
Welcome, Dr. Jaswant Singh. How are you?
Yeah. I think it's the first dental school in India, De Montmorency, is it?
Yes, yes.
Yes, correct.
It's
Yeah.
De Montmorency is
Yeah.
the dental school in the province of Punjab, and
Oh.
it's in Lahore.
Mhm.
And pre-partition, it was more than 100 years. The school is here.
Yes, in fact, I visited the school also when I was in Lahore, and also that President Arif is also a common friend of us. All right, he's an orthodontist and also a friend, used to be in the FBI Council. All right, so I also noticed that Dr. Ulan Angesta, okay, Dr. Ulan, you can right now unmute yourself and you may ask question because I see that you're putting out your hand. Dr. Wen, you may unmute yourself. Huh? Okay, so while waiting for them to unmute, I do see two questions in the question and answer here. All right, the first is by Dr. Rifani. All right, first of all, he thank you, Professor Syed Faisal, for the very interesting topic. She's asking that regarding the aligner. The first one is that can aligners also be used as occlusal splint in patients with Bruxism? Okay, maybe I'll ask that question first before I actually ask the second question. Professor Faisal?
Yes, it's a very good question. Thank you very much for asking this question. Basically, aligners, in aligners, we give, according to malocclusion, different number of aligners, like mild cases, moderate or severe cases. Sometimes we give 10 aligners, 15, 20, 25, more than that. It depends upon the severity of malocclusion. In splints, yes, it can be used as a splint, but in splint, we just give one aligner, one sheet of set of aligner for that. So it can be used as a splint in bruxism, and also is a good option when bruxism is present. If we use conventional braces, then the chances, if the patient is still bruxing with conventional braces, then the chances are there he might debond brackets very frequently. But with the bruxer, we can give aligners in bruxism.
Okay, very good. Thank you very much, Professor. Then Dr. Rifani asked a second question. Will the bruxism interrupt the aligners movement?
Basically, if we see the mechanism of aligner, that how they are working, aligners are working individually in an arch. They are not working in two arches. So individual arch, if the for the maxilla, there is a separate aligner. For the mandible, there is a separate aligner. And as I have discussed in my presentation, with increments, the teeth are moving in small 0.25 increments. So in Bruxer, the patient is not bruxing if he is wearing the upper and lower aligners. His centric occlusion and tooth relationship is changed, and still the treatment can be done in Bruxer if the patient is wearing aligners. And especially, I will discuss the key and take-home message. Key with the aligner is that as an orthodontist, if we give aligner to any patient, then we say if there are few things left after aligner treatment, we can still give for a short duration of time braces, and we can correct that malocclusion with the braces. And if the treatment is of 1.5 or 2 years, 1.5 years if the patient is wearing aligners, if there are any settling issues, if there are any translation or few tooth movements left, within 2-3 months, within a short period of time, we can correct those with a conventional braces. So
Okay.
that's the key to success, that when a patient visit us for consultation, aligner patient visit us for consultation, we do tell them that if we see that the finishing is not good at the end of treatment, we can correct that with we include that in our package, conventional braces.
Thank you. And the last
Welcome.
question Dr. Rifani asks is that, right, is aligner indicated for cases with other bad oral habits, the parafunctional habits?
Yes, if the orthodontic treatment is recommended for because of any malocclusion, the parafunctional, like the digit sucking and the other habits, some of conditions, if we give start treatment around 7 years of age, and because of the habit breaking, the problem is ceased, problem of that digital sucking or any other oral habits have reduced or finished, we can give aligners to those patients. And we can always modify the aligners according to our need. But these days, aligners companies are coming up with more scientific research and better aligners with attachments, more tooth movements are possible within aligners. We can give aligners to those patients.
Okay. All right. So I shall ask one more question before I pass over to my co-chairman, Professor John Ling. So this question comes from Dr. Sabah Noshin. The question is, at which time an orthodontist consult to surgeon for treatment of sleep apnea?
Basically, we don't consult. It's a teamwork. When we talk about obstructive sleep apnea or sleep breathing disorder, if at early age, mostly the child visits us for orthodontic problems as tooth screening. As a dentist, we recommend that at its second to third birthday, just child should visit dental clinic to see what are the dental setup, not for any treatment. If during any routine dental checkups or orthodontic checkup, patient is coming, just ask few questions, and if the patient is at the risk, then we refer that patient to sleep physician, who then diagnose patient and say that either he is a sleep breathing disorder or not. Once he is diagnosed by the sleep physician, medical professional, that he is a patient of sleep breathing disorder, then if it's because of both jaw retrognathia, then orthodontist is involved in a team, and first we give different splints to diagnose anterior repositioning splints, in which the mandible is, if the mandibular retrognathia is severe, then the chances of sleep breathing disorder, obstructive sleep apnea is there. First we correct it with oral appliances, and then afterwards, if it's confirmed that it's because of retrognathia, then we refer patient to oral and maxillofacial surgeon. And the timing of treatment is mostly we refer our patient for surgery when the growth has completed. So in late teens, and after adulthood, after 20s, we refer our patient to oral and maxillofacial surgeon for biomax surgeries.
Okay, thank you so much. Okay, so now I shall pass over to Professor John Lee. Professor John Lee, there's a question also in the Q&A. Yeah? Mm-hmm.
Oh, I'd like to clarify with Professor Faisal. To update you, people want to live longer. Hong Kong has now become the longest living life expectancy city in the world. Sorry, it's not Japan anymore. We beat them by 0.29.
Thank you very much. I have checked few. Thank you very much. Thank you. So I just wanted my audience to think on these scales, and thank you very much. You indicated that if we only are limited ourselves to oral care, orthodontics, malocclusions, if we are diagnosing, because we are the physicians which are opening the mouth of the patient, and if we are by simple few questions, looking at the soft palate and the tongue position of the tongue, if we are diagnosing that for the lifetime, we are just referring those patients, we are doing good with them. And the life expectancy, I think so that in Hong Kong, the people are taking more care of their sleep apnea and other, and if in any country lifestyles are good, then there are chances that their life expectancy will improve. In our country, we are struggling with healthy lifestyle. So because of that, different diseases like coronary artery disease, diabetes mellitus, and other diseases are more prevailing in our country, and some other parts in which lifestyles are not so good. Thank you, Professor John Ling.
Similarly, our teaching at the university also with the master course in orthodontics, we do pay a lot of attention to sleep apnea and how to treat them, and then observe them at a very young age, as you have described. Now, I would like to ask a question. At what particular age we would stop treating older patients? Because every now and then I have patients, I'm an orthodontist myself, in their 60s and 70s coming for treatment. So what is your idea of this, as long as the periodontium are healthy, the patient is, in general, the dental health is good, would you recommend orthodontic treatment to a patient maybe in their 60s, when they retire, or when they are 70s? What age will you stop doing any sort of orthodontic treatment?
Thank you very much, Professor, for asking such a good question. Basically, I'm also involved with a university in which we do teach postgraduate orthodontic. We are running a postgraduate orthodontic program, and it's called Fellow of College of Physicians and Surgeons, Pakistan. Last we had, in few years back, we had a competition of all the postgraduate exams of the world in United Kingdom, and our College of Physician and Surgeon Pakistan stood first in that postgraduate exams, because our program is a 4 years program in which we amalgamate both clinical and like research based. So in our program also we teach our students obstructive sleep apnea, breathing disorders. In this presentation, mostly I was aiming that my audience is general dentists, so I limited myself for diagnosing and haven't discussed the orthodontic aspects of sleep apnea, that how we, which appliances we use, how we correct those, and some details. Regarding your question, sir, that at what age, basically, if when we do orthodontic treatment, it's basically remodeling. Whenever remodeling is present, periodontium is healthy, yes, we can treat patients around 60, 70, 80 years of age. And mostly some of the time, different our colleagues like prosthodontists and oral and maxillofacial surgeons, implantologists, we formulate treatment plan with them. Like if the multiple teeth are missing, if the teeth are at an angle, if they are not straight and the prosthodontists are having difficulties in aligning them, then at any age, if we see there is no absolute contraindications, other contraindications of health, we don't see any condition in which we stop treating our patient. Basically, these days, it was a discussion also that either orthodontics is an aesthetic treatment only or it's for health also. So initially it was thought that the orthodontic treatment is aesthetic for aesthetics only. Now, if their teeth are aligned and the patient teeth are aligned, then the life expectancy of that the teeth have also improved. So in our country, not like you, that the patient age is not like that much, but if the patient is interested, especially in Europe, we have seen that patients in initial age don't have that much money to give to orthodontist for tooth correction. So they visit after retirement, they get most of the money, pension and amount, and then they come for aesthetic treatment, orthodontic treatment linked with aesthetic treatment. So we do provide orthodontic care to 60, 70 and 80 years of age. I hope so. I'm able to answer your question, Professor.
Maybe I'll ask one more question.
Please, more than welcome.
If you say, for instance, would you recommend tooth movement to treated periodontal patients, which they start off with poor periodontal health, and then they were treated successfully, but the teeth are still mobile? Would you recommend orthodontic treatment still to those teeth which require movement? If the teeth are still mobile.
If the active problem, basically the periodontal ligament is the bread and butter of orthodontist. Fine. So if the periodontium is diseased, then we don't start treatment. If in active disease we start orthodontic treatment, it will cause more harm and cause more fast detachment of periodontium. So in cases in which there is an active disease, we don't start orthodontic treatment. We are not able to treat patient, and it will cause more harm to the patient. But once, if we refer patient to periodontologist, and if active disease is controlled. I was lucky enough that in my training, as I referred to you, he was also the FDA chairman, president, Professor Dr. Arif Alvi, my supervisor. He is also the prosthodontist and also involved in caring periodontology, periodontal health of them is lost. We once the periodontist say the patient is fit periodontically. Now these days we use sticky bone, PRPs, multi factors, and we just periodontist and oral maxillofacial surgeon regrow the periodontium of the patient. Then we can start with the orthodontic treatment. But a very good question, sir, for the participants, that if there is an active disease, we don't start any orthodontic treatment, not about the periodontium. If there is any other condition, if there is any decayed tooth, any other BDs, first of all, we'll resolve all the dental issues, and then we'll start with the orthodontic treatment.
I pass back to my president. Need to unmute yourself.
Unable to listen to you.
Dato, you need to unmute.
Yes.
Sorry. I forgot to unmute myself. My apology. All right. So we received many compliments for your excellent presentation. Okay, we have from Dr. Jaswant Singh, Dr. Rifani, Dr. Sabah, Dr. Jaswant again, Salima, Jawad, and many more people. All right, so I'd like to thank you really, really for your excellent presentation. But just before I close, I just want to ask one question regarding our common friend also, Derek Mahoney, all right, about the treatments of the sleep apnea in children. Okay, so how do you early intercept this problem? Would you mind to share that with us?
So sorry, can again you come up with a question?
Oh, yeah. Okay. Sorry about that. The management of sleep apnea in growing child. All right. Is there a way to
Yes,
detect and treat this one and reverse it? Mhm.
yes. Mostly if we see with the questionnaire, if the problem is present, uh, if there are allergies, if there are problem in oropharynx, nasopharynx, mostly the problem is present at the nasopharynx or the oropharynx. And these days we can see deviated nasal septums, tonsils, adenoids, allergies are present. And first of all, we have to diagnose what's the problem that's causing obstructive sleep apnea. If it's the position of the tongue, if it's the jaw which is small, we then address that problem and simple with the anti-allergics, with the weight management, with referral to the ENT. We can, and we also make anterior jaw repositioning appliances. If the mandible is short, Professor John Ling is with us. We give uh, functional appliances so that the mandible can be growth. There is more space at the back for respiration. By doing all these things, first of all, coming at the diagnosis, what are the points which are causing that child problem? We can correct obstructive sleep apnea, reverse obstructive sleep apnea. And if it's a very important question, Dr. Hao Kim Chuan, that if we are reversing the problem in the child, then all the skeletal and other effects which are not created, like every other health issue can be more worsen with this obstructive sleep apnea, like uncontrolled diabetes mellitus, arrhythmias, cardiac problems, all these are present. If we correct those in early childhood, then the patient might not develop these problems, or if the problems are developed, then the severity is reduced. So yes, we can very easily, by identifying the cause of the problem, can correct the problem and reverse it.
Thank you so much. Okay.
Welcome.
Once again, I'd like to congratulate you and thank you wholeheartedly for your excellent presentation and obliging to ICD. We really look forward to invite you and hope to see you in person. I shall now hand over to our education chairman, Professor Muhammad Ibrahim. Professor, over to you. Thank you.
Yeah, thank you very much, Dr. Hassan John and also Dr. John Ling for moderating the session. And also on behalf of section 15, we'd like to thank you, Professor Dr. Faisal, for sharing his experience with our audience tonight. And at the height of the meeting, although we have 100, more than 100 registered, attended our meeting on this Zoom, and another about 12 on our YouTube channel. Okay, so of course, we had about 996, 84 registered on our web page, on our webinar today, but only maybe, so some reason only about 100 plus are able to join us to listen to you, Professor Faisal. Again, on behalf of I'd like to thank you for you to share your experience with our audience tonight, and we hope that it's really useful for our audience. And okay, and on for next to move on, of course, I just like to, as usual, we will have another session this month, about on the 22nd of September. However, our speaker has approached, mentioned yesterday that he is not well. He might not be able to join us on that day in 2 weeks' time. Anyway, I'm not working on another speaker for the 22nd. It'll be in the same discipline, but I'm just yet to confirm the title. And if anything comes up by the end of this week, I should be able to announce the topic for on the 22nd. So I just like to, on behalf of Section 15, I'd like to say a few words that the speaker that's supposed to join, to share with us on 22nd is our Vice President, actually, but he's not well. So we hope that he will recover soon and he will to join us later, or if not on the second, later part, or maybe in the October session. So again, with this, I think I'd like to thank you all our participants tonight for coming to join us at this webinar, and hope to see you again in 2 weeks' time. And again, on behalf of the committee, I thank you all the speakers, the moderators, the participants, and also my team, Dr. Mayna and Dr. Emmy, has helped in putting this webinar tonight. Thank you very much, and see you all in 2 weeks' time. Thank you and good night.
Thank you. Thank you.
Thank you very much. Thank you very much, International College of Dentists, all the organizers, facilitators, Professor Mohammed Ibrahim, all the participants. I had lovely time presenting this. And if anyone have any questions afterwards also, they can go to the YouTube channel of International College of Dentists, and you can ask any questions at that time also. More than welcome. Thank you very much again for inviting me at such a big platform. Thank you.
Thank you.
Thank you. Thank you.
Okay, bye-bye.